Hello friends, welcome you all to this wonderful session on NEET PG 23 PSM question discussion. So what we have done is that we have tried to put forward the best version of this recall based questions. Okay, the questions may not be exact because it's based on the memory of the students after giving the exam. Okay, so let's begin. First question, 10-year-old child was presented to the OPD. Which vaccine would you advise according to the NIS? So 10-year-old child, obviously the first thing that strikes your mind, TD, yes, tetanus, diphtheria. Okay, previously it was TT, now it's TD. At 10 years and 16 years, you have to give TD. Okay, so here the answer is TD. Okay, let's just quickly brush up this NIS, very important part, National Immunization Schedule of the syllabus. Birth dose vaccines, BCG, OPV, birth dose and hepatitis B. At 6 weeks, you are giving the DPT, OPV and hepatitis B along with the Haemophilus influenza type B. Then you have the rotavirus 1, fractionated inactivated polio vaccine 1 and pneumococcal conjugate 1. Okay. At 10 weeks, see 10 weeks what is absent? At 10 weeks what is absent is that this particular, you have the DPT, you have the OPV2, you have the Hep B2, you have the Haemophilus influenza type B2, you have the Rota V2. What you don't have is that you don't have the fractionated IPV and the PCV. Okay, the fractionated IPV and the PCV is at 6 weeks and 14 weeks, not at 10 weeks. Clear? So 14 weeks, again DPT3, OPV3, hepatitis B3, Haemophilus influenza type B2, rotavirus 3, and again FIVV2 and PCV2. Because at 10 weeks there was no fractionated inactivated polio vaccine and the pneumococcal conjugate vaccine. Okay, 9 months you have the measles rubella 1 and the J Live 1, the booster of the pneumococcal vaccine, vitamin A 1 lakh international units, and we know that vitamin A 1 lakh international units you are giving at 9 months. So then every 6 months you have to give 2 lakh international units of vitamin A, okay, of vitamin A up to the age of 5 years. Okay, I repeat, 9 months 1 lakh international unit of vitamin A, then every 6 months you have to give 2 lakh international units up to the age of 5 years. 16 to 24 months you have the DPT booster, okay, the OPV booster, the measles 2 or the MR2 and the J Live 2. 5 to 6 years will be another DPT booster. So this was the question, 10 years TD, okay, and another TD booster at 16 years. And for pregnant women, TD1 and TD2 should be taken 1 month apart. Okay, moving on to the next question. A 22-year-old pregnant woman presented to sub-center, okay, the most peripheral division, with history of eating papaya. She is suspecting that she might have aborted the child. You have to examine her thoroughly and advise her that her pregnancy is safe and she can go back home. Which health worker will be sent for rural visit for this kind of situation? So see, I have tried to take the best version of this question. Okay, this question is a bit informative question, but what is asked in this question, the most important thing I want you to know is that regarding nutritional education. Who gives nutritional education to a pregnant woman? That is what is the crux of this particular question. Okay, so which health worker will be sent for rural visit for this kind of situation? Who is giving the nutritional education to this pregnant women? Now, so we know home visits can be done by whom? ASHA. The first thing that comes to the mind is ASHA. But also home visits under the ICDS is done by whom? By the Anganavadi worker. Okay. Now, in between ASHA and Anganavadi worker, you have to choose who will be able to give this nutritional education. Okay. ASHA does not give nutritional education. Nutritional education about which food substances to avoid during pregnancy is usually given by the Anganavadi worker. Okay. So here the answer will be Anganavadi worker. Okay. Not ASHA. Okay. If you are writing ASHA, then it will be wrong because ASHA is usually giving other sort of advices regarding contraception, okay, regarding iron folic acid tablets, okay, regarding any other medicines required, okay, but usually regarding this nutritional education, the advice is given by the Anganavadi worker. We'll just go through. As you know, ICDS basic 1975 centrally sponsored scheme aims at providing services to preschool children of the rural, tribal and the slum areas, okay, and the Anganavadi worker, they are the heart of the ICDS, this we know. ICDS service, what are they? Number one, supplementary nutrition. immunization, health checkup, medical referral service. See, this is the point from where the question is asked. Nutrition and health education for women. So when you look at this type of question, what do you infer? You infer that the questions are not that hi-fi. It is strictly textbook question, but you have to have your basics absolutely clear. Got my point? Non-formal education for children aged 3 to 6 years, okay? And also non-formal education for pregnant and nursing mother in rural, urban and tribal areas. So see, non-formal education for pregnant and nursing mother. And here under education, nutritional education is also included. So this point and also this point, it is stressed under ICDS. Anganwadi worker is going for home visits and providing what? Nutritional education. Okay. So that was what the question asked, that she is suspecting that she might have aborted the child, because we know that fruits like papaya and pineapple should not be taken during pregnancy. They are abortifacients. Okay. So somebody has to examine her thoroughly and advise her pregnancy is safe. Basically, we are talking about the nutrition education, which fruits or which other food substance to be avoided during pregnancy. Clear? And who are the ICDS beneficiaries? Children 0 to 6 years, as we have discussed, pregnant and lactating mother, women in reproductive age group, and the adolescent girls. Okay. So adolescent girls 11 to 18 years under the ICDS, we call this the Kishori Shakti Yojana. So basically what I'm trying to say is that this Kishori Shakti Yojana is under what? Is under the ICDS scheme. Am I clear? Some more important MCQ points on ICDS because I'm discussing this. Okay, some important MCQ points. Focal point, you know, Anganwadi worker, one Anganwadi center per 400 to 800 population in rural and urban areas. Okay, one Anganwadi center per 300 to 800 population in tribal areas. Okay, these 2 points you should know. Okay, ICDS administrative unit, this will be the community development block. Okay, and each community development block is covering 1 lakh population, and one community development officer is in charge of 4 supervisors and 100 Anganwadis. Clear? Let's move on. Next question. A study was conducted among 2 groups of people working in aniline dye factory for 20 years to know the incidence of bladder cancer. Please read the question again. Look here. Study done among 2 groups of people. So we have got 2 groups of people, okay? Working in aniline dye factory, okay? So whenever we are discussing about aniline, we know it's an occupational hazard that aniline can induce the formation of urinary bladder cancer, okay? For 20 years to know the incidence of urinary bladder cancer. So basically you have to go back 20 years, yes or no? You have to go back 20 years and ask people regarding the exposure and then track them to see at present day whether they are developing bladder cancer or not. So I'm already given you a hint about the answer. Now group 1 is what? Group 1 is the people directly working in the factory, and group 2 is office workers. So you can definitely understand that group 1, the people who are directly working in the factory, they are exposed to aniline, whereas those who are doing table work in the office, they are not directly exposed to aniline, yes or no? So what is this type of study? So again, what you do is that you have got 2 groups of workers. One is direct factory workers and one is office workers, okay? So you are going back 20 years. You are going back 20 years using this particular data or the records of the factory and see who are exposed directly to aniline. And then you track them back in up to the present and see whether they have developed bladder cancer or not. So what do we call this? This will be an example of retrospective. Retro means going back and then coming. Retrospective cohort study. This will be what? Retrospective cohort study. If you ask me, sir, what is mixed cohort study? Mixed cohort study will be, see, suppose this particular cohort, you have gone 20 years back, you have taken the history of their exposure to aniline. Now you come back to the present and see how many of them have developed bladder cancer. Now suppose another person, a friend of yours want to take forward this study. So this particular cohort, he studies for another 15 years. Okay, suppose there were 100 people who were exposed to aniline working in the factory. And over the span of 20 years, around 30 of them have developed bladder cancer. So now your friend is interested, okay, 70 has not developed the cancer so far. So let me track them for another 15 years in the future and see whether they will develop the cancer or not. That will be what? Mixed cohort study. That will be what? Mixed cohort study. Okay. So because we are not having any future element, we are going to the past and then present, not to the future. So it will be what? Retrospective cohort. Clear? So I have given you one retrospective cohort study design. One more example so that it is absolutely clear in your mind. So it's basically a combination of cohort and case control. So what are the steps? Suppose I say I go back 10 years and I find 100 smokers and 100 non-smokers, okay, from the hospital data. Trace them, not back, trace them to the present and ask them, that is both the smokers and non-smokers, that is how many developed lung cancer in the last 10 years. Now you understood? Go back 10 years, look at the hospital data, okay, the history, smokers or non-smokers, 100 smokers, 100 non-smokers, and trace them back to the present and see how many of them have developed lung cancer. That is retrospective. Now suppose those who have not developed lung cancer so far in 10 years, if you want to trace them in the future also, if you want to follow them up in the future also for another 10 years, that will be what? Mixed cohort. But up to the present is what? Retrospective cohort. Clear? So what is the advantage? Advantage is that you can understand or you can get the incidence of lung cancer among both the groups, okay? And also you can calculate relative risk, attributable risk, okay? And it will save time, okay? It will save time. Mixed cohort study. I'm giving you one example here, mixed cohort study. Suppose I say I find 100 smokers and 100 non-smokers from hospital records 15 years ago. We arrive at the present to see how many have developed lung cancer. And another investigator wants my data and wants to follow up my cohort for another 15 years. Okay, that is 15 years prospective component added. Okay, retrospective component was for 15 years and you follow those non-lung cancer cases, non-lung cancer patients for another 15 years. That is a prospective component added. So retrospective plus prospective, mixed cohort study. Clear? Case control study design, you know, that is 100 lung cancer patients are taken as study subjects in the year 2020. The investigator checks in the year 2005 how many of them were smokers. Okay, 70% of them gave a history of smoking. So smoking appears to be an important cause of lung cancer. That is a case control study. Okay. A new question. So a question like this was asked. Now some students say that it was asked regarding tap water. Some said that it was asked regarding hand pumped water. Okay. So I have gone with tap water because that was the majority which I got. So how to collect tap water for bacteriological study? That was the question. So simple thing you should know, whether you collect tap water or whether you collect this hand pump water, okay, you leave that particular tap open for 2 to 3 minutes or you pump that hand pump for 2 to 3 minutes, okay, so that the service line is cleared. Once the service line is cleared, then you take the next stream and from there you see, okay, that's the rule usually. So remove external tap fittings such as rubber tubes or hose attachments. See, turn the tap on full and allow to flow for 2 to 3 minutes to clear the service lines. This is the point you should be knowing for this answer. Okay, you allow the water to flow for 2 to 3 minutes to clear the service lines. Adjust the flow rate to gentle stream of water and collect without splash. Very important, collect without splash to ensure streamline flow. Okay, what's the answer here? How to collect tap water for bacteriological study? Okay, so best answer here is option A. Before collecting water, let the water flow for 1 minute. And what is the purpose I told you? To clear the service lines. Done? All these are, see, attach bottle before turning on the tap. No. You have to clear the service lines. You just cannot put the bottle like that. Okay. Now this is the protocol. There is a certain protocol about how to collect the water and in which bottle to collect for bacteriological analysis. And this is the Winchester bottle. Okay. The Winchester bottle for bacteriological analysis of tap water, hand pump water, whatever. Okay. Next question. Very important question. 22-year-old female presented to OPD with history of vaginal discharge. Vaginal discharge and cervical erosion. See, one habit to do in the exam when you are reading the question, okay, you just focus on the most vital points. Vaginal discharge and cervical erosion. They have not said cervical discharge, they have said cervical erosion. And this is the game changer here. Because if it was cervical discharge, it would have been grey kit. But they have said what? They have said cervical erosion. Which color kit do you advise? Okay, see, vaginal green frothy discharge plus cervical erosion, green colored kit. But if they have said cervical discharge or urethral discharge or anorectal discharge, cervical discharge, then it would have been grey colored kit. Treatment also differs, okay. For grey colored kit, we are going for azithromycin and cefixime. For green colored kit, secnidazole and fluconazole, okay. So white kit what? White kit is a non-herpetic discharge, okay. Genito-ulcerative disease, non-herpetic discharge. In this case, you have to go for penicillin. But suppose the patients have allergy to penicillin, you cannot use penicillin, okay. Same case, genito-ulcerative disease, non-herpetic, allergic to penicillin, then you have to go for azithromycin and doxycycline, okay. That is a blue kit. I repeat, white kit and blue kit difference. This can also be asked in future NEET PGs, okay. White kit means what? GUD, genito-ulcerative disease, but it's non-herpetic and also the patient is sensitive to penicillin. In that case, you are using penicillin, benzathine penicillin. But what is the blue kit? Same case, GUD, non-herpetic, but patient is allergic to penicillin. In that case, you have to go for what? Azithromycin or doxycycline, okay. That is a blue kit. Red kit, genito-ulcerative disease, herpetic. Obviously, you have to go for acyclovir, okay. And yellow kit is basically a diffuse symptom, lower abdominal pain, then you have to go for the broad spectrum antibiotics, cefixime, okay. So for the exam, you should definitely know red kit, blue kit, white kit, green and grey, okay. This time, basically you have to select between grey and green, okay. Grey, cervical discharge, green, cervical erosion. So what was the question asked here? The question was asked here, vaginal discharge and cervical erosion. So what is the answer here? Yes, it's a green colored kit, okay. It's a green colored kit. Done. Next, what is the best measure to assess health status of a community and utilization of health service? This is absolutely chocolate question, direct question. Assess health status of community and utilization of health service, infant mortality rate, okay. Infant mortality rate. Infant mortality rate formula, you know, number of infant deaths in a given year divided by total number of live births in the same year into 1000. IMR is the second best indicator of socio-economic development of a country. So you can ask me, sir, you are saying IMR is second best indicator. What is the best indicator? What is the best indicator of socio-economic development? Answer kya hoga? U5MR, under 5 mortality rate, okay. What is the best indicator? Yes, under 5 mortality rate. What is the best indicator of state failure? Infant mortality rate. IMR is the most important indicator of health status of community, level of living, effectiveness of maternal and child healthcare service. So question was framed from this point, okay. We don't know the exact language of the question, but the question was framed with respect to this point. They asked which is the most important indicator of health status of community, level of living and the effectiveness of MCH service in general, okay. So answer will be IMR, infant mortality rate. Infant mortality rate accounts for 18% of total deaths in India. This is the recent data. Most common cause of infant mortality in India is low birth weight. Most common cause. But suppose I say, look at this particular point I am discussing here. If they ask you most common cause of infant mortality in India, you go for low birth weight. But suppose in the option you also get prematurity, then you go for prematurity. But if prematurity is not there, go for low birth weight, okay. So if both low birth weight and prematurity are in the option, then prematurity is the answer. Am I clear? Let's move on. Most common cause of infant mortality in the world, pneumonia. Next question. Now this is a very unexpected question. Colombo plan, not asked in previous years. Usually we do not read it before the exam, okay, because there are so many plans to read, not Colombo plan. But again, Colombo plan is given there in the park textbook, okay. So again, what we infer from this is that you cannot leave any topic point and go for the exam, okay. So Colombo plan is basically a question that radiotherapy, cobalt isotope, okay, cobalt therapy units were procured, okay, from Canada. That was the Colombo plan. So the question was regarding the cobalt supply, okay. So Colombo plan, as you can see, regional organization that promotes collective intergovernmental effort to strengthen economic and social development of members in the Asia Pacific region. Membership of 20 countries, AIMS at New Delhi, established with financial assistance from New Zealand. Canada, see, Canada supplied cobalt therapy units to medical institutions of India. As we know, cobalt 60 isotope is used in radiotherapy. So, cobalt therapy units were supplied to India by Canada under the Colombo plan. So, answer will be what? Answer will be cobalt therapy units. Next question, which among the following deficiency will cause diarrhea, dermatitis, dementia? Again, absolute chocolate question, lollipop question. Direct answer, what is the answer? Diarrhea, dermatitis, dementia. So, your diagnosis will be what? Pellagra. As we know, what is pellagra called? Pellagra is called the 4D disease. Okay, diarrhea, dermatitis, dementia, and death, and it happens due to deficiency of vitamin B3, that is niacin. It's not exactly the fault of niacin. We know that tryptophan is converted to niacin. So those who are maize eaters, maize consumers, maize will contain one amino acid called leucine. So if a particular population is having maize based diet, then there is excess leucine amino acid in the body. And what does leucine do? Leucine will block the conversion of tryptophan to niacin. In that case, there will be the niacin deficiency symptoms like dermatitis, dementia, diarrhea, that is pellagra. Okay. So ultimate culprit is what? Maize. What does maize contain? Leucine. And what does leucine do? It will block the conversion of tryptophan to niacin. Am I clear? So see, 60 milligram of tryptophan is converted to 1 milligram of niacin. That is the clue, or that is the most important point here. So in case of tryptophan deficiency, there will be niacin deficiency. So always remember that niacin deficiency is secondary to tryptophan deficiency. Tryptophan we know is an aromatic amino acid, right? So maize eaters can suffer from pellagra. Why? Because maize contains excess of which amino acid? Leucine. And what does leucine do? It will block the conversion of tryptophan to niacin. Okay. And this is the classic appearance of pellagra. As you know, pellagra 1D is dermatitis, and in dermatitis there is a rash around the neck in the pattern of a necklace. Okay, we call this what? We call this Castle's necklace. So Castle's necklace actually is the rash. It is the rash of pellagra. The Castle's necklace is basically the rash of pellagra. You can see this particular rash here, Castle's necklace. Dermatitis over the neck, over the trunk, okay, and also over the hands, along with dementia, diarrhea, and ultimately death. Okay. So if it's an image based question in the forthcoming PGs, they can give you this particular image and ask you the diagnosis. So what is the answer in that case? Pellagra. Next question, a 10-year-old child presented to the pediatric OPD with fever, rash and Koplik spot. Done, diagnosis done. Koplik spot appears 24 to 48 hours before the rash of measles. Yes or no? So here the answer is measles. Koplik spot usually appears on the buccal mucosa. Identify the diagnosis, measles. So this is Koplik spot. You can see these white spots. These are the Koplik spots. Okay, the white spots on the buccal mucosa. These are the Koplik spots. So causative agent of measles, a quick discussion, RNA paramyxovirus. Measles incubation period you should know, approximately 10 days to 2 weeks. Acha, measles, the source is case. In measles there is no carrier. So because in measles there is no carrier, what does measles not show? Measles will not show iceberg phenomena. Does not show iceberg phenomena. Measles does not show iceberg phenomena. Measles does not show iceberg phenomena because the source of infection is only what? Case. What is the mode of transmission? Droplets. Okay. Period of communicability, very important. This you should know, this point. Period of communicability of measles have been asked in previous PGs. Okay. So it is 4 days before the onset of rash, up to 5 days after onset of rash. 4 days before onset of rash. See, I told you, Koplik spot. The Koplik spot usually appears 24 to 48 hours before rash. Okay. So Koplik spot is included in the period of communicability. So period of communicability means 4 days before the onset of rash and up to 5 days after onset of rash. Up to 5 days after onset of rash. Okay. Secondary attack rate is very high, 90%. That is why measles can become a very fast epidemic, okay? Diagnostic feature, yes, Koplik spot. Located on the buccal mucosa as a bluish spot on the lower second molar. Bluish white, actually not exactly bluish. It can be pure white also, it can be bluish white also, okay? Remember, this appears 24 to 48 hours before the rash. Okay? Look at this one. What is this? Identify the vitamin deficiency in the child whose image is given below. So look at the pattern of the leg like this, na? We call this what? We call this bow legs. And we know that bow legs, knock knee, these are all what? Vitamin D deficiency, okay? These are all vitamin D deficiency. They are part of which disease? Rickets. We know that vitamin D deficiency in children will cause rickets. In adults, it will cause osteomalacia. Yes or no? So bow legs and knock knee, answer is what? Vitamin D deficiency, rickets, okay? Next, quick. An alcoholic patient presented to OPD with ataxia, confusion, visual changes. Identify the cause of the disease. First of all, alcoholic patient comes to OPD with ataxia, confusion, visual change. You have to go for the diagnosis. Wernicke-Korsakoff psychosis. Wernicke-Korsakoff psychosis. It usually occurs in alcoholics with which vitamin deficiency? Deficiency of vitamin B1. And what is B1? Thiamine. Don't say thymine. Thymine is a nitrogenous base. Thiamine, okay? And vitamin B1 deficiency usually leads to beriberi. In alcoholics, it can lead to some neural disorder that is called Wernicke's-Korsakoff psychosis. So this patient is Wernicke's-Korsakoff psychosis, and here the answer is thiamine. As you can see, chronic alcoholic thiamine deficiency, Wernicke's-Korsakoff psychosis, okay? So these sort of questions you cannot make mistake, you have to answer fast, okay? High yield points on thiamine deficiency. Thiamine deficiency is affecting which population? That population who is eating polished rice. And polished rice consumption is predominant in Andhra Pradesh and Telangana. Polished rice, it will be vitamin B1 deficient, okay? Polished rice is vitamin B1 deficient, okay? And here the incidence of beriberi is very high. So this can be a distribution based question in the future PGs, okay? Andhra Pradesh, Telangana, polished rice consumption. Which of the following can be the disease? What is the answer? Beriberi. Deficiency of which vitamin? Vitamin B1, thiamine. Apart from beriberi, thiamine deficiency can lead to Wernicke-Korsakoff psychosis in whom? In alcoholics. Next question. Again, a very, very vital question. See, one question definitely you will get from the National Health Program. This time it was asked from NTP, National Tuberculosis Elimination Program. A patient came to TB with chest symptoms and with sputum negative, but chest X-ray finding are suggestive of TB. What is the next best step? Okay. So what is the information given here? Sputum negative. Chest X-ray finding are suggestive. What is the next step? So before I tell you the answer, you know the answer. Before I tell you the answer, let's just go through the flow chart, a very vital flow chart. For a TB patient or a patient whose sputum smear is positive or sputum smear is negative, but the chest X-ray changes are suggestive of this particular TB, okay? And also there is symptoms, fever, hemoptysis. So first of all, you have to look at the HIV status. If the patient is HIV positive, go for CBNAT. If the patient is HIV negative, go for sputum smear and chest X-ray examination, okay? If sputum smear positive, declare as a case of tuberculosis. If sputum smear negative, look at the chest X-ray findings. If the chest X-rays are suggestive or not suggestive of TB, but the signs and symptoms are present, one sign and symptom can be hemoptysis, fever with evening rise of temperature, loss of weight, fatigue, all these are classic tuberculosis features. If the chest X-ray is suggestive or not suggestive, but the symptoms are there, what do? Go for again CBNAT, okay? If CBNAT is negative, then you go for an alternate diagnosis. If CBNAT is positive, look at the type of rifampicin resistance. If rifampicin sensitive, declare as case of TB. If rifampicin resistant, start the rifampicin resistant management. If result is indeterminate, perform a second CBNAT. So ultimately, whatever be your problem, go for what? CBNAT. So what will be the answer here? The answer will be what? CBNAT, cartridge based nucleic acid amplification test, CBNAT. Okay. So when you see this particular video again, you should definitely go through those particular flowchart I have discussed here. Okay, it's very important because this can be again repeated later. Okay, so whenever there is a problem of HIV negative, sputum negative, chest X-ray not suggestive, symptoms are there, always what we are going for? CBNAT. If after everything CBNAT is negative, you have to go for alternate diagnosis. Okay, next question. Clean cut wound in a male. Look at the question. Clean cut means what? No laceration. Clean cut wound in a male with tetanus toxoid received 10 years ago. What should be the management of the wound? Okay, look at this table, all of you. Okay, clean wound. If there is a complete course of tetanus toxoid or booster taken within the previous 5 years, nothing is required. Even if it's a lacerating wound, nothing is required. But the tetanus toxoid or booster should have been taken within the previous 5 years. Okay. Now, if there is a complete course of tetanus toxoid or booster taken within 5 to 10 years, then if it's a clean wound, you have to go for single dose TT. Others, lacerating wound, single dose tetanus toxoid. Tetanus toxoid taken or booster taken more than 10 years, single dose TT, single dose TT. But suppose you don't know the immunization status, okay, or the tetanus toxoid or booster is not taken. In that case, both in case of the clean wound and others, you have to go for toxoid complete course. But in others, along with the toxoid complete course, you have to give the immunoglobulin, that is both the active and the passive immunity. But if you look at the question here, what is given? Clean wound and the tetanus toxoid in that male is taken 10 years ago. So here the answer will be single dose TT. Okay, if they say that it's a lacerating wound, not a clean cut, and the patient's immunization status is not known, then you have to go for this one, full dose TT with tetanus immunoglobulin. Okay, and no treatment required is when it's a case of clean cut and the tetanus toxoid or booster has been taken within 5 years, then you can go for no treatment required. But it is said 10 years ago, so you have to give single dose TT, or within 5 to 10 years, single dose TT. Less than 5 years, no intervention required, provided clean wound. 5 to 10 years, single dose TT. 10 years ago, single dose TT. Immunization status not known, TT plus the immunoglobulin. A patient does varicella, the management for contacts, not the case. If you are given case in the exam, you have to go for this acyclovir, antiviral drug, okay. But contacts, what do we do? Contacts, we have to go for isolation and the immunoglobulin. So here the answer will be isolate for 2 weeks plus varicella zoster immunoglobulin within 48 to 72 hours. This is the answer. Okay. Isolation for 2 weeks plus the varicella zoster immunoglobulin within 48 to 72 hours. Okay. Acyclovir is given for the cases, not contact. Please note this down. Okay. A baby born with prematurity has low birth weight. Repeat question. Low birth weight, decreased hearing, patent ductus arteriosus, classic bilateral cataract. It will be what? Congenital rubella syndrome. Yes. Congenital rubella syndrome, as we know, this vertical transmission usually occurs in the first trimester of pregnancy, right? If the transmission is occurring after 16 weeks, then the chances of this hearing damage, eye damage, heart damage is less. Okay. So if the infection occurs after 16 weeks, then there is no major abnormalities. So what is the triad? The classic triad will be congenital heart disease. The most important is patent ductus arteriosus, cataract and sensorineural deafness. Okay. 7-week pregnant female came to PHC and has hemoglobin 9 gram%. When is iron tablet advised? See, iron tablet, listen to me, iron tablet is usually advised after the first trimester. You know why? Because in the first trimester, the patient or that particular woman, not patient, that particular pregnant woman is already having problems of nausea, gastritis, which is very common in the first trimester of pregnancy. So if you give iron folic acid tablets in the very first trimester itself, this will alleviate those particular symptoms of nausea, gastritis, vomiting, yes or no? So usually the iron tablet is given after the first trimester, that is from the second trimester onward. But this is for those particular women who has hemoglobin more than 11 gram%. But here you see the hemoglobin is 9 gram%. So the patient is suffering from anemia. there is anemia. So in this case, you cannot wait up to the second trimester. You have to counsel the patient. You have to say that you are suffering from anemia. You need iron tablets as soon as possible. And these tablets will have this particular side effects. The problems of this nausea, gastritis you are having, it will increase, but you have to take it, okay? Because you are having low hemoglobin. So you have to give it as soon as possible. That is after 8 to 10 weeks of pregnancy. And this is what I've written here. Just go through the points. In pregnancy, iron tablets are started in second trimester if hemoglobin is more than 11. This is done to prevent any further nausea and gastritis, which a pregnant woman usually suffers in first trimester. But if she is anemic, she has to be put on iron tablets as soon as possible. And so here, if you look at the options, as soon as possible, the lowest value is given is 8 to 10 weeks, so we will go for that. A poor farmer develops progressive spastic paralysis, upper motor neuron signs and gait instability, which is the most likely toxin involved. You can understand it's a neural disease toxin. So it has to be beta oxalyl aminoalanine, and this will be a case of neurolethyrism. Okay, so we know neurolethyrism, it happens due to what? Intake of what? The khesari dal. The khesari dal, which is having this particular toxin beta oxalyl aminoalanine, BOAA. Okay, so khesari dal, neurolethyrism. So that is why khesari dal consumption and selling is usually banned. But even if it is consumed by mistake, accidentally, against the law, vitamin C can be a neutralizer. Okay, so what are the treatment options for neurolethyrism? Vitamin C, ban crop, parboiling, steeping method, health education, out of which vitamin C is best, but best thing is that ban the crop, don't consume this dal, no, not required. Some more questions which I have heard from the students. Okay, not put the options, just we can discuss it. Raw egg consumption leads to deficiency. So see, lot of vitamin deficiency questions. So that's why, you know, every year I say this nutrition chapter is very important. Nutrition chapter in PSM, it's a very scoring chapter also. Nutrition, national health programs, okay, epidemiology. So these three topics that you should revise before your exam. Okay, if you ask me selectively which I should revise, you should revise everything, but nutrition, lot of questions are being asked from nutrition. Last year also, if you see, lot of vitamin deficiency questions. Okay, nutrition, national health programs, epidemiology. Okay, so these topics you should be revising. Raw egg consumption leads to deficiency of which vitamin? Biotin. What is the answer? Biotin. Cement worker with X-ray changes showing mesothelioma. Absolutely. Mesothelioma is a type of lung cancer. This is specific for asbestosis, as we have discussed in our occupational health disease, that asbestosis is a case of occupational lung disease with chances of cancer. And what is the type of cancer? Mesothelioma. Okay, asbestosis. Zinc deficiency is associated with acrodermatitis enteropathica. Acrodermatitis enteropathica basically have two important causes. One is the zinc deficiency, and acrodermatitis enteropathica can also be genetic. Okay, it can also be genetic. Note down this particular point. I have got one image for you. This classically the facial appearance of a child infected or affected by acrodermatitis enteropathica. Mainly you can see the lips, the area surrounding the nose, the area surrounding the eyes. This becomes reddened, inflamed. Okay, acrodermatitis enteropathica. Bleeding manifestation linked to deficiency of, yes, vitamin C. We know that vitamin C deficiency leads to scurvy. Why does scurvy occur? If we can go to the basics, why vitamin C deficiency leads to scurvy? Why? Because see, vitamin C is what? Vitamin C is basically ascorbic acid. Okay, vitamin C is basically ascorbic acid. And what does ascorbic acid do? This ascorbic acid, it will convert an amino acid lysine to hydroxylysine. Okay, and also it will convert proline to hydroxyproline. Lysine to hydroxylysine and proline to hydroxyproline. And this hydroxylysine and hydroxyproline, this two, hydroxy forms of the amino acid, they are required for collagen formation. Collagen, as you know, collagen is the very important protein present in the connective tissue. The collagen fibers are coming out from cells called fibroblast. So this collagen is forming our gum tissue, okay. So hydroxylysine, hydroxyproline required for the formation of collagen. If this collagen is not properly formed, obviously gum bleeding can occur, and that is the manifestation or the symptom of what? Scurvy. Okay. So we have discussed the questions. A quick discussion we had on the questions which were probably asked on recall basis in this particular NEET PG. I've already told you that the topics on which you have to stress, okay. So keep on revising, look at this video again and again, okay, and over the past 2-3 years, look at the pattern of the questions. So ultimately what inference we come to, the questions are not that hi-fi questions. They are not absolutely from another different planet, okay. They are strictly in your textbook, okay, strictly in your syllabus. So what you have to be thorough with is that you have to be thorough with the entire syllabus, okay. Just be consistent, keep on studying consistently, have a definite time period in a day. I'm not saying that you forget all other activities, okay, and this applies for all subjects, okay. Just stick to your textbook, okay. Thank you.